Fine, thank you. So maybe we can now introduce this case. Can I have the slides maybe? Yeah, so this is a case where we want to use the bullfrog system to inject dexamethason, but also use potentially the TAC system if we have dissections to treat after ballooning of an anterior artery occlusion. See, it's a relatively young patient, diabetes patient as well, missing here, forefoot ulcerations. He had already quite some treatments of iliacs, but also SFA. Also SFA left this month, quite calcified. Next shows you, please, next slide here. The below the knee situation. You also see some popliteal stenosis, which we have treated recently. You see the peroneal artery going down, foot arteries very small. We think the dorsalis pedis arteries is a good target, filling the forefoot arteries better than the plantar branch, which also may be difficult to reach. It also appears here already, I mean, angio looks like calcium, although this is not fluoro image. Okay, next shows you our intention, left antegrade, 6 French, guide wire passage, and then predilation and dexamethason injection, and TAC if necessary. Well, we prepared already the case, and again, it turned out to be relatively complex. So first, the SFA had quite some calcium on our way, and now the system doesn't work anymore. Just a moment.
One short question, Andre. It seemed as if the origin of the perineal was also diseased in your introduction angiogram.
Yeah, there's also a little stenosis. I think we have to do another angulation to turn that origin away from that collateral.
Yeah.
Although I think the flow is, sure. This can also, I think this also needs to get treated. But you see the anterior, there's a little channel going down, and now, I think proximal part you can see already that this is really quite some calcium here. And this is all over the artery. Well, this of course makes this a relatively difficult case, I would say, first of all, for wire passage, ballooning, but potentially also for the bullfrog system. Yeah, so forefoot, I really think here dorsalis pedis should be the target with the forefoot lesions. And so we passed the wire to the distal portion, then the wire is perforated. It was not so easy to get down here, but at the end it worked with a PT2 plus WIN 200T. And then we, predilated here, still some traces of that perforation. And then as I said, the WIN 200T went down. Once again, I think you can now appreciate once again that wall calcification. Thomas, do you think this is a case which is feasible to do with bullfrog, or?
Well, at least in part it looks like as if you crossed in the true lumen. So it might make sense. There where we can see the marker, I'm not so sure whether it's still in the true lumen or subintimal. I have only experience with the bullfrog in intraluminal crossing attempts. I don't know how it works if you are applying this device from a subintimal space.
Yeah. Well, I mean, essentially, that's what you're doing. I'm pretty sure that So, I think, Andre, essentially, that's what you do when you inject. So if you inadvertently fell somewhat into that space, it should potentially do exactly the same what it's made for, huh?
Yeah, it should be even easier if you are subintimal.
Yeah.
This is very
I'm pretty sure I passed interluminally. I think we took care about this. I think if you, with this venous sclerosis, if you get subintimal, that always is difficult to get back, and that at the end was not so difficult. Okay, so here we reached it, and then we ballooned with 2.5 tapered balloon. And here is the result after giving some nitro. Still some residual stenosis, proximal part. As Thomas said, the peroneal stenosis still has to get treated. Dissections, well, proximal, yes, but otherwise so far okay. But here we have quite some recoil. Mm-hmm. Yeah. So nevertheless, the artery reaches really nicely now the forefoot, and yeah, I think we still have to balloon once again here that artery, especially proximal, before we take the bullfrog in. Otherwise, it will be a little bit narrow here. Den Dreierballon haben wir.
So what's your experience with the bullfrog with regard to the profile to reach the distal tibials? Is it the reason why you are going in now with a bigger balloon to create a lumen which is big enough due to the, let's say, a little bit bigger profile than usual with a balloon-based approach?
Yes, so it's recommended for arteries not smaller than 2.5. So therefore, I think I should try to make it a little bigger. Yeah, we also have used it in 2 millimeter after 2 millimeter balloon dilatation. But I think if we can make it a little bit better, and in fact also if I would not use bullfrog here, I would be happy if I could increase the diameter here a little more.
Plus, while you do that, I mean, ultimately this is kind of a touch-up therapy, if you may, on the way out. So you would have to be comfortable with what it looks like before you put the bullfrog in on your way out of the procedure. So as is right now, there's still a reason to believe that there's some more work to be done, Andre, so I would agree with you. Are you going like with a 3.5? I mean, it looks like a big vessel, and you may want to tack it nicely up, or what are you selecting diameter-wise?
It's a 3.0, I believe so.
Yeah, actually the 2 millimeter balloon already was actually painful for the patient. Therefore, I'm not sure whether I can really go down with here 3. I think 2.5 may be maximal. Maybe it was also the length of the balloon which was painful. That's my hope. Not so much the diameter, but probably also the diameter. Okay, well, not so bad. Maybe it opened up a little bit more after some more waitings after nitro. Siehst du den?
Or it's simply the other angulation which gives you a better lumen now. Yeah. But it's a nice case for TAC implantation later on.
Okay. Yes.
Andrew, you mentioned that the patient already had pain when you did the ballooning. Can you tell us about your experience when you inject the needle into the vessel wall? Do the patients also feel pain, or?
Well, yeah, good question. Usually not. So we had one patient who felt some pain, but other patients didn't feel it.
And do you have experience with other drugs than dexamethason? You know, just to compare if, you know.
No, up to now we have just injected dexamethason. The other studies are ongoing in the US, not here.
We're currently enrolling in
so we are
Tango.
not involved in that.
Mm-hmm.
And Tango is now using tanserolimus. Mm-hmm. So I think we've enrolled 6 patients, but it's randomized. So we're blinded at this point as to the results of that. But no pain at the same time. Regardless if it was placebo or maybe drug, they haven't had that much pain.
320.
The difficulty, I think, remains what we were talking about, where when you have calcium, it's hard to get that little needle through that. And so you have to kind of
look for spaces.
Look for that sweet spot where you could actually inject past the artery, which I believe would be probably impractical in very severely calcified vessels to begin with.
You have to be very patient during the procedure and look for these spaces.
You have to be very patient, like Andre. You have seen Andre. He's got an incredible amount of patience to do this.
Oops. Oh. Yeah. So it really depends. So 2.5 was not so painful for the patient distal, but here in that proximal part, it is even more patient at lower pressure. This is really sometimes interesting. I think it may also depend on the severeness of the calcification. Pressing maybe here more calcium outward.
And probably depending also where you are located with your balloon, if you are in the true lumen or subintimal, that's also predictive for
that,
pain.
yeah.
And there
but
was
proximally definitely were interluminal, because there was a little
more painful.
Open. Yeah.
There was also some concern about dexamethason injection in patients with infection.
Okay.
Corticosteroids that having a bad impact on infections. Did you see any worsening? Because we did not see in our cases.
No.
Not in particularly, no.
Ready?
It's unlikely that the dose you apply around the vessel has any systematic effect.
Okay.
So you are now ready for...
We need one more ballooning.
Okay.
One more ballooning, sorry, with a 320 proximal. And then we can take the bullfrog. Guckst du oben?
Ja, ich gucke. Also oben, ja.
So did you get stuck with the bullfrog proximal, or why are you going in again?
Na, ist hier jetzt.
Using a bigger...
because we saw on the previous angio some residual stenosis proximal at the anterior origin. So that's why I take 320 now.
Yeah.
Just going a little bit into the anterior here. Das drückt nochmal. Now this is okay for him. Okay. Fine. So maybe Sven, you can bring already the device to show. I will give some nitro and then introduce the bullfrog.
So the bullfrog system, is it over the wire or monorail?
Yeah, so this is the newer version, the over-the-wire system, which really improved. Better push. You can now even torque and rotate the device, bring the needle to different positions, directions. So I think very helpful. Of course, a little more bulky maybe. So that looks already quite nice. And big enough for the bullfrog.
Yeah.
That's okay, huh?
Very nice.
So what's your plan? Are you going to treat the entire length of the anterior tibial down into the dorsalis pedis with the bullfrog, or what's the idea?
Yeah. Yes, exactly. So actually down to the bifurcation here of the tarsal artery from the dorsal artery. This is where, where the occlusion ended.
Down there.
And we start distal,
It's really small.
and then we go up.
I think if you were, especially if you got attack, it seems like.
Yeah.
Right.
So if you are in a subintimal channel, do you have any concern that by injecting a given volume of this drug, this volume might result in some compression of this subintimal lumen? Did you observe something like that already?
Well, theoretically, yes, but actually we have never observed it. It's, I would say, not 0%, but very rare that you have to post-dilate after using the bullfrog device. And I actually cannot remember a case where we really thought, kannst du den Draht ein bisschen zurückziehen, that a residual stenosis or recoil was due to some compression from outside from that medication. No, not really. Okay, I think I start here now, and we magnify now. Kannst du mal so, kannst du mal das im Bild mitnehmen? Ja, warte, sorry.
So you have a ruler in place. Does that mean that the patient will be enrolled into a study, or is it simply for orientation that you know exactly how much distance you have between the different injections?
Yeah, so actually for the bullfrog we usually do not use a ruler, because with a mix of dexamethason and contrast you actually can see quite nicely how far that mix spreads proximal and distal, although it also spreads over time, not immediately to the full length. It is actually rather for the following treatment with TAC systems. There I think you definitely need the ruler to orientate. So here you can see now at between 440 and 430 two distal proximal markers marking the ends of the balloon, and in between a small triangle marker. And if I inflate now the balloon, two triangle markers should actually separate, but this is maybe now not the fact, because on that small balloon maybe only one marker. I thought there were two. Okay, but you can see now the marker going away from the wire. That means the balloon is inflated. You can only give a pressure of 2 atmospheres. Then there's an overflow valve that prevents the stretching of the balloon. Now I'm ready here to inject 0.25 milliliters or maybe a half a milliliter here into the arteria. For demonstration I will do in DSA. That's then easiest way to, oops, so this, something was wrong here. Once again. Oh. Yeah, here you could see a little bit of contrast mixes went into the arterial wall, but you can see the contrast going down. That means at that point the needle did not really penetrate the calcification.
Really just to deflate and turn it around a little bit?
Sorry?
Said probably deflation and then torquing the catheter a slight bit to...
Yeah, I can try to torque it. I can try to maybe go a little higher to see whether there's some area with less calcification, but I think there is even more calcium. You can only try once again here.
This device will help non-surgeons understand how painful it is to do a distal anastomosis sometimes. Everywhere you put the needle, you hit a calcium.
Oh, this is a nice injection.
Okay, that's great.
That's more beautiful.
Yeah.
So now you can see it on that side. It's also partially going circumferentially to the other side, but especially spreading proximal distal. So that's how we want to see it. And now we go a little higher, maybe 2 centimeters higher here. And try this here once again. But I expect, in fact, some injections not to go into the surrounding perivascular tissue because of the calcium here. That's also nice. So now it looks as if it would only go to one side, but over time we will see it spread also to the other side.
This would have been my next question. Would it make sense to alternately inject once into the right, once into the left orientation? And number two,
so
would it be possible to rotate the system?
I would say yes, it may make sense to do this. Now you can see these 2 markers. Actually, this is the angulation with this angulation. I cannot show you the 2 triangle markers which should separate so that you know that the balloon is fully opening. Very hard to see here now with this angulation. And I said in the beginning, this device, you can rotate it, twist it here.
That's always the problem of the ruler.
We should.
Yeah. Now it's clearly visible.
Yeah. Exactly. Yeah. So I said you can twist and rotate this over the wire device nicely, but in fact, in this very long occlusion here, it's a little difficult, and I may have to go out and in again. Nicht korrekt.
So what's your current strategy? If you have finished the drug application, are you going in again with a long balloon for a final post-dilatation, or do you leave the vessel?
No, usually I do not go in with post-dilatation. So we will search then for dissections and use tuck system. That's the plan. But otherwise, if we would not plan to, no, we usually do not post-dilate. Usually it's not necessary. Let's say it like this. So also here, this is a nice injection. Looks a little spooky, but that's how it should look like.
You say you go in and look for dissections. You have now injected, this mixture of dexamethason and contrast agent. So how you will do that to be sure that you do not miss dissections?
Maybe I didn't really get you. You think it will be difficult to see
I think it will be difficult to see the dissections,
Yeah.
With DSA, it should be feasible.
This went into the artery again?
Do you think IVUS?
Yeah, but with potentially, if we have time to show you IVUS would be nice. We would, in this case, that's actually a good point. It may be more difficult with all this contrast around the artery to see dissections, and therefore maybe IVUS would be a good idea.
Can we turn his mic on?
So here again.
No, I was just going to ask, we were discussing at the beginning of the case whether an initial IVUS run would have been helpful because there were some question marks about size, question marks about subintimal, question marks about where the dissections are. Now it's going to be a little bit harder, I think, to visualize.
So the last 2 ones were not effective. I think here in this area I have more calcium. Effective again.
It's very spooky.
Okay, kannst du ein bisschen vergrößern, damit wir sehen, wo wir ungefähr sind?
Vergrößern?
Also verkleinern.
Verkleinern, ja.
Ein bisschen aufmachen. Yeah, so how many centimeters do we have to go? Can you show the anterior? And still a way to go. Yes. So what are your plans? Do you have a presentation to give? And kannst du wieder zeigen?
We have you on the program to give a talk about the limbo trial.
What?
There's a limbo trial update by Andre by means of satellite. Is that something that we're not necessarily doing?
That's true?
Oh.
Sorry, I thought Dirk.
So, vielleicht der.
No, I believe you have still about, you have 13 minutes. So, much time left.
1-3 or 1-3 or 3-0?
1-3.
1-3. That's not so much. That's not so much.
For
Okay. Again, sometimes it's only partially successful.
Yeah.
Yeah, so I don't think I can do the full treatment here in that time because, in fact, really I probably will do the whole length needle to that direction and then potentially twist it and go down again.
Brian is around. Maybe
left.
back to
We have no talk left.
Nice.
or is Brian?
I can't.
He's over there.
Look at you.
Yeah, Brian.
Okay.
How are you, young man?
Yeah. Okay. Yeah. Okay. Let's do that. Yeah.
So maybe we can ask you about the limbo trial. Andre, how many patients?
No. Yeah.
Braun, ne?
Yeah.
Braun.
Okay.
How many patients are in the limbo trial so far?
Yeah. Well. Yeah. Go ahead. Andre, just.
Yeah, sorry. Acoustics a little bad now. Very interrupted. Can you repeat or?
Well.
How many patients are in the limbo trial? Because I think we're all looking forward to see the results of this. Because
Okay. Well, actually, I'm not completely informed of how far we are, but I think we did 2/3 of the patients here in Europe. I know that the trial with George Adams has completed inclusion, atherectomy plus DEXA versus atherectomy only. Here it's balloon. Yeah, we were not as fast as he, so we still have to wait for the results. Yeah.
Okay. So.
Too bad.
Andre, to make it less painful for you, to talk about things you don't know in detail, we will interrupt you now for a couple of minutes for a talk, and I would like to ask Brian de Rubertis to give his talk, which is initially scheduled for the next session, Atherectomy in BTK disease, contemporary data and ongoing trials.
Ich weiß nicht, dass ich den halten sollte oder den halten. Ist er wieder weg? Ist er weg? Ich weiß es nicht. Ich bin nicht informiert darüber.